The plan is you will have your company this thing presentation. Then Dr. Oertel will start with his presentation.
Yes, sir.
Dr. Deopujari will introduce him.
Yes, sir.
And then he has 3 different topics.
Yes, sir.
Between one topic, after finishing the one topic, we will have a little bit of discussion and question answer.
Yes, sir.
So that it should not be a very long, tiresome lecture.
Yes, sir.
For the presenter also and for the listener also.
Yeah.
And then I will talk about my topic, and then we will have question answers and discussion. Yeah.
Yes. And I will introduce Dr. Deopujari sir, sir.
Yes. Yes.
Yes, sir.
Yeah.
Yeah. Shall we start?
Nilesh.
Santosh.
Just a second, sir. Prashant will give sir your.
Go ahead, sir. Start it.
Yeah, Nilesh.
Yes, sir.
Yeah, just have a look on the chat, this thing, and the questions which will come during the presentation. Yeah.
Deepak sir, you are live.
Yeah. Yeah.
Very good afternoon, doctors. Thank you very much for joining us on this international webinar put together by Dr. Rohidas and coordinated by none other than the leading neurosurgeon of India, Dr. Deopujari sir. And we have an international speaker, Dr. Oertel. This webinar is put together and carried to you by Health and You through DigiNeuro, a digital initiative by Health and You Therapeutics, a joint venture with New Link Company Limited, Japan. We have a vision of fulfilling unmet medical needs by launching innovative first time in India products. For example, Amnurite, the first amitriptyline plus mecobalamin combination. It also comes in a lower dose of 5 milligrams. So Amnurite 5, 10 and 25, so that you can titrate the dose in migraine, tension type of headache, and in diabetic peripheral neuropathy. Then when in migraine, when one drug is not enough and you would like to give a combination, we have Amnurite beta, amitriptyline plus propranolol combination, Amnurite beta 520 ER, Amnurite beta 1040 ER. We also have the first pharmacological combination for neuropathic pain when 2 neuroanalgesics come together. Pregabalin, as you know, is a BID dose. It cannot be combined with amitriptyline, which is once a day. So we have made pregabalin once a day with TXR technology to match pharmacokinetic profile of amitriptyline. So Amnurite P once a day gives 24 hours pain relief in severe neuropathic pain. Then we have the only made in Japan imported mecobalamin injection, Neurite injection, to give your patients 100% mecobalamin with the highest quality in diabetic peripheral neuropathy, low back pain. We continue to innovate and we introduced for the first time clobazam 2.5 milligram dose in mouth dissolving form. So we have Adclobaz 2.5, 5, 10 in epilepsy to add flexibility and add control in down titration, in up titration, and also if you want to give a BID dosing. And our innovation continues. Very soon we'll be launching a vitamin therapy for migraine, Brentamine, which contains riboflavin 200 milligram, magnesium 200 milligram, and CoQ10 10 milligram. This is as per American Academy of Neurology, a supportive therapy in migraine. So with your support, with your advice and suggestions, we'll continue to launch innovative and first time in India products. Thank you very much for giving us this opportunity to carry this webinar. I have great pleasure now in introducing the person who does not need any introduction, Dr. Deopujari sir. He is a leading neurosurgeon of India. He has done fellowship in MGH, Neurocastle, England, and Henry Ford Hospital, USA. Sir is a visiting faculty in many international universities like Shinshu University, Japan, like Emory University, USA, and Indian Institute like SGPJ, Lucknow, and AIMS, Delhi. Sir has been a speaker in international symposium of world-known bodies like WFNS, ASNS, ACNS, and World Endoscopic Congress. Sir has published innumerable books and contributed to chapters in textbook and neurosurgery. Sir is past president of NSI, ISPN, ASPN, and skull-based surgery ISNO. Sir is currently a chairman of WFNS, Neuroendoscopy and Neuroendocrine Committee. Learning from sir is a dream come true. I have great pleasure and privilege to hand over this session to Dr. Deopujari sir. Sir, over to you.
Thanks, Mr. Naik. I think today is all about endoscopy, and Dr. Rohidas has asked me to moderate this session. It's a great pleasure to invite a good friend and colleague, Professor Joachim Oertel. He has several innovations to his name in endoscopic and minimally invasive neurosurgery. And today he is going to talk to us about three important topics. So I think the first one, he is going to start with history of neuroendoscopy, and then probably he'll be ready to take some questions, and then we'll start the second talk about the future. And then he's going to also tell us about the experience with the Exoscope, that is the Vitom. So over to you, Professor Oertel.
Thank you. Thank you. It's a great pleasure for me to be back in India, although traveling is so difficult. The first part, the future, I will make just a short presentation. Since we had this webinar, I think about 3 weeks ago on, about the history, will be only a short presentation because we had this webinar already 3 weeks ago where I covered the history.
Yes, sir. Yes, sir.
So let me see. Is it working? You see my screen?
Yes.
Yes.
Okay, perfect. So I have a couple of patents with Karl Storz company, and I used to act as a consultant, but the future of neuroendoscopy with Karl Storz is still a little bit uncertain. This is where I'm from. It's Europe, map of Europe. And this is right, a small city, 40,000 inhabitants, close to the French border. And you see 1 hour drive from Frankfurt Airport, 1 hour drive from Luxembourg Airport, and 1 hour drive from Strasbourg. Its department is about 10 consultants, about 20 residents. Right now we're 32, but it's changing a little bit. We have 4 theaters and a total of 94 beds with 20 ICU beds. And we do 300 to 400 endoscopic procedures per year. On the upper right, you see the neurosurgery department, and this is the campus of the university hospital. It's a traditional department. We have done first this microdiscectomy here. At least it's under discussion whether it was done here or with the Yashagil in Zurich. And the Casper system was developed here, so it's a lot of spine history in this department. I will briefly come to the development of endoscopy, and I think the milestone is the development by Bozzini. It's the so-called Lichtleiter, so light conductor. He was born in Mainz, so which is about 1 hour drive from here, and he went to medical school in Mainz and Jena in Germany, and he used to work in Frankfurt, so which is a little bit farther, maybe 90 minutes from here. And he was a general physician, and he developed this Lichtleiter where he used a candle as a light source in combination with a speculum. And he reported his data in a small Frankfurt newspaper. He reported it to a small group of physicians in Halle in Germany. And then later in this year 1806, he presented his data in Vienna at the military academy. And well, he was not, his work was not much appreciated. He received a lot of critics and it was considered to be impractical. Unfortunately, very shortly later, Bozzini died on typhus in 1909, so he never really applied the Lichtleiter in a larger case series. Then, about 40 to 50 years later, a similar system, also with a gas light source, was used for urology. And this instrument was named for the first time endoscope. So this was the birth of the terminology endoscope with a single optical canal by Desormeaux. And about 100 years later, 100 or 70, 80 years after the development of Bezzini Nietzsche, and together with Leiter from Vienna, he introduced to the market electrical light source endoscope with a lens system, which looked very similar to the cystoscopes we use today. This is the principle of the Nietzsche Leiter endoscope. You see, it's an electrical light source, a lens system. So it's quite a step from the beginning with a candle and then a gas lamp to this electrical system. And about in 1809, also another German company, it was a Wolf company, it developed the first endoscope with a calculated optical system. So you might be familiar with this company because this is just a subsidiary of this company, it's Revo Spine. You see, this looks almost like an endoscope today. And another step was the introduction of the rod lenses by Hopkins. So he developed or reduced the air in the endoscope system in the telescope, which led to a much improved optical quality. Basically, the endoscope now is filled with rod lenses, and there's very, very little air where the lights cannot be conducted as well. And this is the last, major development. It's about more than 50 years ago now, with the technique for endoscope and telescope. Then there were further developments, particularly in the 80s and 90s, introduction of the cold light source, the improvement of the camera systems, and many centers then started to do endoscopy. Particularly, I'm familiar with the centers in Germany, which were like Gab and Panetsky and Bauer. And the term minimally invasive neurosurgery was coined by Bauer and Helwig in '91 in a publication of Neurosurgical Reviews. And actually, this paper dealt with the application of the endoscope in cranial neurosurgery. So when we think about indication for digital imaging, and this will be the major talk I give today, we think about intraventricular application, endonasal applications, transcranial, intracranial applications, and spine endoscopy. Particularly spine endoscopy is becoming more and more important, and particularly when we look at the exoscopic systems, I think there's a huge market, huge interest in endoscope and exoscopes or digital imaging in spine applications. I think I will stop here, and then I will now continue with the exoscopic systems next talk. But I'm happy to have any questions right now, because this is the brief introduction to the history.
Joachim, thanks very much. Though many landmarks are probably now known to people interested in endoscopy, I am particularly fascinated and not very sure about the contribution of Bauer and Helwig, you said.
Sorry?
Bauer and Helwig.
Yeah.
What innovation did they? Is it just the use of the? Did they use the GAP scope, or what did they use?
No. How can I go back to my face? Do you see still my how can I show you the camera?
Your slides are seen, sir.
Huh?
slides are seen.
You see my slides? Okay.
You are
So,
there in the or you can go there and pick it up. Pick the slide you want to project.
okay, it's fine. Well, actually back then in the 80s and 90s, there were different systems available, and Bauer and Helwig, they developed a system with I think Zimmer company, which is not on the market anymore, and they used this system, and they used actually a stereotactic frame with a flexible scope. And Panetsky and Gruner, they started their application with a rigid scope with Esculap and stereotactic frame, and Garb used the Garb endoscope with Storz without stereotactic guidance. They used navigation as soon as it was available. These are the basic principles. And actually Bauer and Helwig, they started, when you look at the first papers, they looked like, they evaluated like the use of the endoscope in subdural hematoma removal. So not the application we use today, a different idea how to use the endoscope and what are the indications for endoscopic surgery in neurosurgery.
So they had extraventricular applications as well. And this was in Marburg, or this was in
Marburg work, all Marburg work, yes.
Okay, great. Thanks for clarifying that.
Yeah, it's a pleasure.
So, are there any other questions, Nilesh?
Sir, not the significant question, only just a general question. What is the difference between endoscopic discectomy and microscopic discectomy? That is the only one question right now we have. So we will continue our.
Okay, this is well, this is a very difficult question, and it's a good question. I think it's a little bit beyond the topic of our webinar today, but the thing is, the first goal when you use any technique is to decompress the structure, and you have to achieve pain relief for the patient. And this is the first thing, and it doesn't matter if you use well, magnifying glasses, if you use a microscope, if you use an exoscope, if you use an endoscope, it doesn't matter. This is the first goal, the primary goal. And the secondary goal is to reduce the discomfort and the scarring for the patient. And this is the idea where you come in, you know, and introduce the endoscope or the exoscope. So you can reduce the trauma of the approach. But the first goal you always have to achieve is decompression of the structures. So it depends a lot of the on the individual case. It depends a lot of your individual experience. So particularly, my opinion is you can do a lot of endoscopic application, but if you're not sure, if you feel, for example, you have a dural tear, you're not sure if you treat it, close it accurately, I would not hesitate to open up and to achieve the primary goal, which is decompression of the structures. In the long run, we know that we have even with an open, you know, when you remember lumbar canal stenosis, we did laminectomies 20 years ago. We did sometimes 2-level, 3-level complete removal of the lamina and the spinous process. The long-term results are quite good. It's rather the short-term results where you can really significantly improve when you use a minimally invasive.
But the nomenclature has been a problem because right since the days the tubular retractor systems were started, they started calling it micro endoscopic discectomy. It was very interchangeably used word, though most people did not use endoscope to begin with the tubular system.
Yeah, I agree. From my perspective, this was a marketing tool. They called micro endoscopic, and I never saw anybody use an endoscope. No, it's not true. With a metric system, with the original metric system, except Fessler. Rick always used the endoscopic system, but all the others, and I saw many very known surgeons never used an endoscope with this system.
Absolutely.
But that was the thing, because
This was the question.
the initial metric system has the endoscope was not that good quality.
Oh yeah, very bad quality. You could hardly distinguish a nerve root from disc prolapse. It's much better when you apply a current endoscope now.
Yeah.
You cannot compare this. It's a completely different world.
As a newcomer, excuse me, sir. As a newcomer in spine surgery, so everyone wants to be an endoscopic neurosurgeon. Is it marketing, like for that marketing is also necessary? The newcomer.
Well, I think if you have like a busy practice, like in a busy clinic, and it's in your interest to have the patient as soon as possible at home, and it's in the interest of the patient. So I think if you have the option of applying minimally invasive techniques to reduce postoperative discomfort, you will go for this, and every patient will go for this. So if you offer this and your particular conditions make it possible, then I think I have no doubt that everybody will go for it. I don't think right now that you have to do a lot of marketing, because if you have good results, it's all over the world. Everybody who looks up for spine and brain, surgery, they will sooner or later discuss the option of minimally invasive applications. So if you offer this, the patients will come. They will come and discuss this situation with you. I don't think that you have to do a lot of marketing. It's rather, your marketing is good results. If you have good results for, let's say, 100 cases, you will have another 200. If you have not good results, then it's difficult to, even if you do a lot of marketing, it's difficult to acquire many patients.
Result is necessary.
Absolutely.
Result is necessary. Sir, this is the question from Dr. S.K. Gupta from Agra. He is asking like that, is it only a marketing tool, or what is the difference between endoscopic surgery and microdiscectomy? So I had taken this question. So right now we don't have questions, so we can proceed our main topic.
Right. So
Thank you. Thank you.
I think then we go to the main topic for Professor Oertel today. That is the use of 3D exoscope.
Yeah, thank you. So 3D exoscopic use in spine and brain. This is the topic. And well, same disclosure, same area where I'm from. I will skip this. And now I start with the first part, which is the majority of the cases, and the discussion is spine. And then in the second part, I will cover some brain applications of the Vitom. When we think about spine surgery, well, this is what we discussed just with a question of one of the participants. We think about open decompression, maybe some magnifying glasses, particularly in the big surgery, big reconstructive surgery. Then we think about microscopic applications, exoscopic applications, and endoscopic applications. And I put the exoscope between microscope and endoscope. It's not that it only covers a small percentage of applications. You can also do a lot of cases with the exoscope where you usually use open decompression. So the exoscope is just a way of visualization, and it gives a very nice 3D image with this current types. I will get back to this soon. And I think it's a very good option if you want to cover a wide range of indications with just one technique for visualization. So the most experience I have is with the Vitom. It's a true 3D image with two lenses, two different scopes. So it's a really a true 3D image. I also have some experience with the Aesculap system, and I have no experience actually with the Olympus system. I will get back to these two systems later. what are the theoretical advantages if you use an exoscope? Well, we want to have good illumination at the surface and in the depths of the surgical field, and this is particularly challenging when you compare this with a microscope. And we want to have better ergonomics, which is an important thing, because sometimes when you use a microscope, this is really giving you an awkward, cumbersome positioning. And it should close the gap between microscope and endoscope, as I told you. And I think 3D illumination for an exoscope is particularly important. I had experience with a 2D Vitom before, which I think was, in my opinion, not ready for a wider application in spine surgery, because you lost the 3D perception, which is very difficult when you have a wide range between the tip of the 3D Vitom and the surgical field. The distance between the surgical field, so the range of focus is 20 to 50 centimeters, so which is quite good. And the magnification is 8 to 30 folds. And it's easy to clean. You see here, it just has to be cleaned with surface disinfectant. And the resolution is up to 4K sensor system. This Versa-crane is under construction of a new one, but you see here basically the first version of the Vitom with the two lenses, and here you can turn the image, and here you have two different buttons for further focus and white balance. So what are the questions when we use 3D? Is the intraoperative visualization as good for the surgeon as when we use an endoscope or microscope? What about the assistant? What about the scrub nurse? And is this an alternative in spine surgery for with respect to image resolution, with respect to side effects and surgical limitations? We have evaluated a little bit more than 50 cases, and actually we have published this in World Neurosurgery, I think, about 2 years ago. I will have a small list of papers at the end. And we performed actually all spine procedures, cervical from anterior and posterior, lumbar disc, lumbar stenosis, and some extradural tumors and synovial cysts. So basically our daily business, we applied the endoscope. And in cranial, we applied it in some tumors, aneurysm clippings, and in trigeminal neuralgia. Come to the results. Well, just in general, there were no specific problems. I was quite surprised, because I'm not a 3D lover. I have frequently problems with headache and so on. I was quite surprised that you have a very good focused image when you use this technique. There were no complications with visualization, and all procedures were performed under endoscopic visualization. This is an example here of a cervical disc 5-6, right side, and this is good because we use the right-sided approach. This is the setup. You see here the setup. This is the Vitom. This is the screen. This is the scrub nurse here. That's me, and this is Dr. Fischer, one of our consultants who did this case with me. And you see here that you have a very nice distance between the tip of the exoscope and the surgical field. Of course, this is usually done without magnification. We just did it here for training purposes. And then the exposure of the surgical field. Then you can adjust the angulation of the image. You see here, when you adjust the angulation, it's particularly important when you look ipsilateral in the foramen. So the ipsilateral foraminectomy is usually difficult, and here with this technique it's much easier than with a microscope to have an oblique view. And you see here this application of the diamond burr and the suction device. This is basically absolutely the same than with the microscope. Here is the steering wheel. You can select an area of the screen and zoom in, zoom out, and focus. I will get back to this. This is now the 3D image. Unfortunately, we're not able to show this in 3D, but I'm sure if you in the future attend, and if you're interested and you attend one of these meetings, you will have the option of a true to get the true 3D impression at one of the booths of the companies. As I said, the major companies which provide 3D exoscope use are now Storz and Esculap and Olympus. And you see here, just it's a very focused image here. It's sharp. It's very good illumination. And here the Casper technique is used. Here now you see that we select a part of the screen and we zoom and put it in focus. So all this is done with the steering wheel. I will forward a little bit, and I think one of the big advantages here now you see it's we go ipsilateral, so it's a right-sided approach. We go ipsilateral for the foramen stenosis, and when you angle the Vitom camera, you see that with this technique it's much easier to have intraforaminal decompression on the ipsilateral side. When you use this with the microscope, you have to really put yourself in an awkward posture frequently. And here it's very easy to have a very clear view into the foramen. Again, zoom in and tilting. So this is, I think, is one example with that you have very good ergonomics for the surgeon when you have just a small camera system and not the big microscope with you. And this is the post-op X-ray. Another example, and I think this is a better example to get the idea what we can do when we close the gap between open decompression and microsurgery. This is a laminectomy case with lateral mass screws. And in the beginning, we used to do the foraminal decompression with a microscope, but here, actually with the exoscope, you can do this very nicely. Particularly in these rather wide approaches, so rather large approaches, you have a beautiful illumination. This is now the screwing with the lateral mass screws. Of course, usually this screwing is usually not recorded. We just did this for educational purposes. just to show you the focus quality, you see that you can really read even the small numbers here, the lot number of the screw head. Resolution is very good with this technique. We evaluated at the end 28 spine cases, and this is a part of the paper I mentioned in World Neurosurgery, and it's about the intraoperative visualization was considered to be very good in spine in 10 out of 11 from the surgeon, 11 of 11 from the assistant, and 11 of 11 from the nurse. Handling rated very good by all applicants, like surgeon, assistant, and nurse. What is the one which was not rated very good for intraoperative visualization? This was a problem that was a very, very obese patient, was a small approach, very deep surgical field, and there actually the resolution was not as good as when you use a microscope. So particularly superficial to deep is good. The smaller the approach, the more difficult is a good elimination in the depths of the surgical field. Side effects, we had no side effects, very comfortable application. In spine, there was no limitation in the indication, but when the surgical field was very deep, then in the depths, there was the surgical field appeared to be a little bit dark. So I think this is then compared with the microscope that you would favor the microscope. So is it an alternative to microscope in surgery? I think in spine, yes. So I will come now to the application in the brain. And there, the application is a little bit different. I think we don't do much open surgery, like only subdural evacuation or so, but any intrinsic brain lesion, we usually use the microscope. And here, I think we applied the exoscope in cases where we usually apply the microscope. It was not an add-on for endoscope or an alternative for an endoscope, then rather again an alternative for microscopic application. Again, what are the potential advantages? It's good elimination at the surface and in the depths of the surgical field. This is one of the goals we have to fulfill, and we have to have very good ergonomics. And again, it should close the gap between microscope and endoscope. Here are the two examples of the other companies. This is the Olympus system. So quite a big, it looks like a big microscope. So I have no experience with this system. It's considered to be very good. I talked to two people who use this a lot. Considered to have a very, very good image resolution. I think one of the disadvantages is that it's very expensive compared with the Vitom system, and it's very bulky. You see, it's like a big microscope compared to this. This is the Vitom system, and then there's another system from Escalop. I think this I had the opportunity to use in a couple of applications, and this is also a very nice application with a much smaller. Very easy to handle. Still a little bit bulkier than the Vitom. Also a little bit more expensive, much more expensive than the Vitom, but image is very good. Image is very good. So we can use the blue light and the infrared imaging mode with the Olympus system, and also various techniques to visualize more clearly the arteries. What are the questions for evaluation? And this evaluation we have only done with the Vitom. So what is the intraoperative visualization in the brain for the surgeon, surgeon assistant, and scrub nurse? What is the alternative in brain surgery? Vitom, is it an alternative to the microscope? We have evaluated 16 procedures in the brain. You see here, this is our case series. It's mainly tumor, craniotomy, and tumor mass resection, and 2 lateral supraorbital craniotomies, and 1 for aneurysm clipping, 1 pituitary craniotomy for aneurysm clipping, and 1 trigeminal neuralgia with a retromastate approach. You see, this is the setup. Setup is quite convenient. It's absolutely nice to use it. It's here compared with the microscope. It's very comfortable. It's no problem with the ergonomics. This is the setup in semi-sitting. Semi-sitting is okay. The problem with semi-sitting is a little bit like with the problem you have with the microscope. So I thought that it's advantage to use the Vitom compared with the microscope in semi-sitting, because when you in semi-sitting, the microscope is frequently in your way. You cannot see really the surgical field with your eyes because you have no straight corridor. And this is actually a little bit similar with the Vitom. Although it's much smaller, it's still difficult to have a straight view at the surgical field. So basically, you have to know where actually the position of your hands and instruments is. A case example. Case example here is a 58-year-old male. History of anaplastic astrocytoma. Surgery was 1 year earlier, and they had a recurrent tumor in the motor cortex. We did the fiber tracking and next magnetic evoked potentials and imaging of the motor strip and motor cortex and tracts. And you see here that this is the done with the Vitom, the resection of the recurrent tumor, and then actually here we put in gliadal wafers. This is the situation. Some images from the surgery. You see here, this is a grid electrode with a continuously motor evoked potential recording, and this is the resolution of the image. This is quite an easy case you can do, and you can, in this case, recognize tumor from adjacent brain tissue. This is the setup. Just like any other craniotomy. Then the 3D exoscope is used like a microscope positioning. And then here you see the surgery now. This is recorded in 2D to better show you. And in these intrinsic brain tumors, you will notice one of the difficulties, I think, which are still there and which are a severe limit. It's quite difficult to really distinguish tumor from adjacent brain edema. You see here, this is very obvious, is this tumor. It's the consistency is different, color is different. This is the sampling for the histology. But here somehow it gets difficult in the resection area to really distinguish the brain from the brain with edematous brain from the tumor. I have another example. Patient with multiple focal lesions, no history of cancer. and a single seizure. You see here, this is the left frontal with a lot of edema. And we went in for surgery. I just want to briefly show you the difficulty. The difficulty is to really distinguish the brain from the adjacent tumor. Particularly the closer the color resembles the brain tissue, the more difficult it is to identify the tumor. And I had severe problems in any tumor which is like a benign glioma, grade 2 glioma. Grade 1 is different. Polycystic, for example, usually you can easily distinguish, but those tumors which are very, very close to the normal brain tissue, they are very difficult to recognize with this digital image. And you see here, this is, I think when I look at it, I think this might still be tumor, but it's difficult to distinguish tumor from adjacent edematous brain tissue. So what are the results when we evaluated our cranial cases? There was in 4 cases switched to the operating microscope. And one was for the depths of the surgical field in the supraorbital, very small approach. And then in the depths of the surgical field, it was difficult to have enough light in the depths of the surgical field. Then there was one switch to the endoscope. This was the aneurysm case. This is because we wanted to evaluate the position of the clip and the open branches. And there was another case here with a small craniotomy. You see 2 by 2 centimeters, again switched to the operative microscope because it was difficult to have enough light in the depths of the surgical field. So then we asked the performing surgeons how would they grade the results, the application of the 3D exoscope in brain surgery. It was grading -2 to +2, so significant inferior, somewhat inferior, same as 0, same as operating microscope, and +2 is significant superior to an operating microscope. And you see here when you look at these various results, that handling of camera was rated almost equal to the microscope. Handling of unit, better than the microscope. And recognition of anatomy and pathology, well, somewhat almost the same than with the microscope, which I think I was surprised because I think this is a surprising good result for me. Because I sometimes felt that this is difficult. Illumination on the surface was very good. So illumination was better than with a microscope. In the depths, actually, am I back? Do you hear me?
Yes.
Oh, what happened?
Yeah.
Suddenly we lost the connection. Let me see. Where did we lose the connection? Are you here?
Now. We are able to hear you.
Okay. I will continue. Where am I? Let me see here. Is it okay? Are you with me now?
Yes.
Sir,
Okay.
share your presentation. Share your presentation.
Okay. Okay.
Share screen. Yeah.
Yes. Yes.
Okay. Where did we lose each other? Did I explain the results of the surgeons?
Yeah, you were at the
Scrub nurse.
yes.
Okay, so I think here somehow, does the setup need less time? No, it needs the same time. What is about the organization with the other equipment? It's the same problem, or absolutely the same than with the operative microscope. Well, is the participation of the scrub nurse in the case easier? And they rated yes. So they felt more informed about what is going on during the case than with the microscope, particularly probably because you have this wide screen, everybody looks at it the same. And is it easier to do the instrumentation? No, no difference. Then evaluation of the ergonomics. Was the camera in the way? There was 6 evaluations. 1 is in the semi-sitting. Did the glasses disturb? 1, yes. Side effects of glasses, yeah. 1 surgeon actually said he became headache. And all the others, 5 out of 6 said, well, I felt comfortable. So these are all the six surgeons participated in these cases. And was it easy to learn? Yes, there's basically a very steep learning curve. You need 1 or 2 cases and then you're familiar with the 3D and exoscope. Scrub nurse evaluation, there were 11 scrub nurses participating. And they said, well, they felt the glasses disturbing. They had mainly no side effects of the glasses, but they were just felt it awkward. And was the position of the monitor ideal? No, they think sometimes they thought that they would rather have a little bit more distant of the monitor, which is in contrast to the feeling of the surgeon, who really wants to have it a little bit closer because of the magnification to see every detail. And this is the assistant surgeon evaluation. There were 12 assistants used in this study. You see that the camera was mainly not in their way. They did the glasses, they did not feel that the glasses disturbed them, and there were no side effects. They had a comfortable body posture. It was rather easy to assist. Well, yes or no, there was an equivocal results. So when we look at the brain, it's easy to apply. It's possible in a wide range of indications. It closes somehow the gap between microscope and endoscope. However, in deep-sided lesions and in small craniotomies and in cases where the color of the tumor or the lesion resembles the color of the brain, I think it has still significant limitations. So I would always prefer an microscope for these resections. And these are some of our papers we did on these applications. And I think the doctoral students who collected part of these cases for presentation. And well, we still hope that we will have our 9th Hamburg Neuroendoscopy week in September this year. It's a little bit unclear whether we can really have it or not. And well, thank you for your attention.
Thanks, Professor Oertel. Is it possible on the computer screen to wear 3D glasses and see these pictures?
On the computer, what do you mean? No.
I mean, if I wear a 3D glasses, would I be able to see those pictures?
You need a 3D monitor.
Okay.
You need a 3D laptop.
Yeah.
Are they available?
Yes, 3D laptop is available.
Okay.
They're available, but I personally think that you need a a big screen. The wider the screen, the
Right.
better is the image resolution, and the better is your information about the intraoperative
3D TV,
situation.
3D TV from by LG.
Dr. Oertel, is the 3D Vitom available in 4K, or is it only?
Not yet, but I think it will be there soon.
Okay. And what is your uh, judgment about the image quality while you are operating, say vis-a-vis the endoscope which you use?
Well, the magnification with the endoscope is much higher. So you really have to compare it with the microscope. You cannot compare it with the endoscope, because with the endoscope, and this will be the third talk now, it's a future about the digital imaging. I think we have sometimes such a beautiful magnification that we even see single erythrocytes. And this is not what you can expect from the 3D exoscope. 3D exoscope has a good magnification, but it's not in that detail when you do use the endoscope. So it's not, for example, when you do an endonasal case, with the endoscope, you have much more detailed view than with the exoscope. So you really have to compare the exoscope, I think, with the microscope. And then if you compare it with the microscope, it's because you have such a huge distance between the camera tip and the surgical field. Then I think you will be satisfied. But it's clear, it's a detailed view, it's a nice view, good resolution, but it's not for very small craniotomies, very deep surgical fields. I think then you cannot compare the endoscope. It's much, much better.
Thank you very much for this talk. Are there any questions, Dr. Nilesh?
Yes, sir. This question from Dr. Geet from Delhi. She is asking, apparently a 3D camera works were both 2D and 3D. So one can switch to 3D or 3D to 2D based on what requirement?
Well, actually, I with the 3D with the exoscope, I never use 2D. The 2D is so difficult because you have no depth perception. I think the role of 2D and exoscope is only for record a case, for education, or for documentation. For the surgeon, 2D I think is horrible. I have so much difficulties because you really have not the depth perception. It's very different from the endoscope. The endoscope, the camera, the tip of the camera, the telescope is very close to the surgical field. So usually the depth of the surgical field is from the tip of the endoscope to the target area where you focus is maybe 3-4 centimeters maximum, sometimes 5, but not more than that. And usually you have a suction tip in the surgical field. So you have the brain calculates a 3D image for you. And this is very difficult very different with the exoscope. With the exoscope, you have no instrument in the depths of the surgical field. So you go in and out, and you have absolutely no depth perception. I know that some use the 2D Vitom for thoracic surgery and so on, but I personally, I had a very difficult time, so I did not use it.
Have you found any difference in using it for spine and brain in terms of the same issues that you just talked about? In terms of,
well, I personally think for spine, it's if you think about getting a tool for imaging, and you have no microscope, you have no endoscope, you have no exoscope, and it's then probably the 3D exoscope is a good option. You can cover almost everything with this. I think 99% of indications. In brain, no. In brain, I would say maybe 2/3 or so. So all the delicate skull-based cases, I am very reluctant to agree with that is really, it's an addition. It's not, you know, that you can change from microscope and endoscope assisted to exoscope, not yet.
Fine. So should we go to the next topic? Anything else, Nilesh, in your question box?
Oertel, can I ask, is there any robotic exoscope?
Well, there's still research going on. Right now, I think right now it's not in the clinical application. There's a lot of applications for the robotic surgery in cranial surgery, but it's not that it's really, is introduced to the market as an option. So it's still, I would guess, it's experimental. And actually, this is another thing what we have to have in mind, that the tactile feedback you have with your own hands, it's an unbelievable structure, your hand. This tactile feedback is so delicate and so highly accurate. Right now, no really computer system or robotic system can fulfill the same requirements you can fulfill with your hands.
Basically, I mean, if you look at a completely different system like a synaptive system, or what now Zeiss is coming out with, a navigation robotic arm attached to the system. So you can probably have something like a visualizing robot, but not a surgical robot as such. So I think the exoscope, if it is, can you sort of use it in conjunction with navigation?
Oh yeah.
But not integrated.
Not yet. But it's planned to come, as well for the Esculap, as well for the Olympus system.
Right.
It's the Olympus. The long goal is that it's basically like a navigational robotic tool.
So that's what the synaptive people created, and I think probably it is being taken over by a Stryker, I am told. So we may have some new player in the market very soon.
Yeah.
But the other thing which you showed with the Olympus system is that you can use fluorescence with the exoscope. Is that possible with the 3D Vitom as present?
Not yet.
Okay.
There's a new version of the Vitom, but I'm not aware when it's going to be on the market. And this should integrate the ECG and also maybe 5-ALA, but 5-ALA I think is a different issue because this is a very small indication, very peculiar indication. So mainly I think will be ICG imaging.
Too expensive.
Yeah.
So maybe we should move on to the next topic, the future.
Yeah, thank you. Let me see.
What is the cost of this exoscope in comparison to the microscope?
Well, it depends on the microscope you're buying.
And this storage Vitom, how much it is?
I don't know. I think it's about 30 to 35,000 in Germany. But you have to check with the local
3D endoscope in comparison to 3D endoscope storage, which invoice is the cheaper?
Same.
Cost.
It's about the same. It's a very similar to an endoscopic system. But of course, you can use it in much more applications. So I think it's if you're a busy spine surgeon and you have to buy one technique for visualization, I probably think the exoscope is a good option. But if you have to do a lot of brain cases as well, if you have to do a lot of MIS cases, you need everything. You will not have, you cannot cover everything without microscope. You cannot cover everything without endoscope anymore.
So both these systems you want if you want to operate the brain and the spine both.
Well, it depends on your personal preference. There are so many different options. I think you have to, my suggestion is you should do browse the market, and you need good support, which is also very important. So if you have a good support by a company, then you should pick 2 or 3 different systems. And then with these 2 or 3 different systems, you should just do a couple of cases, which you feel most comfortable with, right? I mean, this is, for example, Dr. Rohidas, he loves endospine. I personally think for me, it's quite difficult, but everybody has a different approach for different surgical skills. So I think you should just try 2 or 3 different ones. You know, for example, if you have a lot of young patients with disc prolapse, the transfemoral system might be a very good option. If you have a lot of patients with stenosis, old patients, I think the transfemoral system is probably not good for you, because if you need a lot of drilling, it's not an option. Then you need a tube system. If you have a lot of fusion, you probably need an MIS combination of application of screws, cages, and decompression. So it depends on your personal preference. If you have a lot of skull base, I think skull base you need an endoscope. There's no option without an endoscope in skull base surgery right now. If you just have intrinsic brain lesions, if you just do meningiomas, convexity tumors, gliomas, probably one of the exoscopes, particularly maybe the Olympus, might be a good option. But you have to have in mind when you look at the Olympus, this is the price of the microscope. It's not cheaper. Okay, shall we continue?
Go ahead. Yes, go ahead.
Okay, let me see. You see the screen?
Yes, clear.
Perfect. Well, most of this we discussed already, and I brought just new trends in digital imaging, technical developments. It's, well, I think exoscope, endoscopic ultrasound, 3D endoscope, confocal laser endoscopy. I think this is very, very interesting for us, and this will, I'm almost sure, will play a part in the future. In which way, I'm not sure yet. And the contact endoscope, you can see a single erythrocyte in the venoles and arterioles, and 5 ala, as we have discussed. This is an example here, I think, for a very nice endoscope resection with an ultrasonic aspirator. You see here, this is a ventricular tumor. You can treat with a 6 millimeter endoscope, just because this tumor can be taken out here with an ultrasonic aspirator. It's a subepidemoma. You see, it's almost no bleeding. It's very easy to remove even larger tumors as long as they have no vascularity with an ultrasonic aspirator. 3D ICG, we have done a lot of discussion on this, and well, this was one of the first cases we did. Actually, that was in 2013 for the World Conference in Seoul in Korea. We prepared a couple of cases with 3D aneurysm clipping. And back then there was no Vitom available. Back then there was no really good 3D endoscope available. So we used this 3D thoracoscope. So it's a 1 centimeter diameter, true 2 lenses, same technique than the Vitom now. But, and you see here, this is the resolution. And actually in these cases, it was quite easy to apply the clip and clip the aneurysm. You see the MCA aneurysm, you see the parent vessel, you see the bifurcation, and there's one vessel here and one there. So it's a trifurcation, 3 levels, 3 vessels in the close to the aneurysm. And this is one option where we did 3D. We did now, as I said, a couple of cases with the Vitom. Well, it has the big advantage compared with the endoscope that if you are in trouble, you still have the option of maintenance of view. This is here the application in 2D of the ICG, and this will be on the market. I'm sure this will be on the market soon. Right now, it's not available for the Vitom. And this, I think, is one of my particular favorites. This is the confocal endoscopy, and we have here the magnification of 160 micrometers in diameter and in depth 80 micrometers. So 3 cell layers by 5 cells in diameter. It's a very high magnification. It's a laser stimulated reflection, and with the endoscope is a detection of the signals. And you see here, this is some embodies of the meningioma. And for example, this is a trabecular network of the meningioma. And we have evaluated this. This is a prototype. It's not on the market yet. It's quite well known in the gastroenterology for recognition of the integrity of the basal membrane and gastric cancer. And you see here, this is our evaluation that we use this confocal technique to distinguish tumor from brain tissue. And here, this is the diagnosis in the frozen section and in the confocal. So it's, well, it's quite a high specificity to recognize the tumor. And I'm sure that this technique will further develop. And then at the end, I think we will use a pen to really analyze our resection margins and to find out whether we have done a complete resection or not. This, I think, is a major step in the future for, well, robot assisted. I would not call it robotic surgery because I think the judgment has still be done by the surgeon, but robot assisted surgery will be there soon, that we evaluate the resection margins and then we discuss the results. And I think the computer will calculate what is the likelihood of that this is a remnant tumor or not. I'm very sure that this will be there in the near future, the next 10 years. This is another nice tool we evaluated. This is the confocal the contact endoscopy. This is the small erythrocytes you can analyze, and you see the flow of these very small arterioles and venoles. You see there's the flow through these small vessels. You can analyze the flow, and we applied this technique in nerve compression neuropathies and in peripheral nerve tumors. And this is a very nice tool to see, to study the microcirculation. And this is also another thing. All this is possible just because we switch now from the analog image to digital imaging. This is the key step. Digital imaging, you have the option of analyzing the structures by the aid of computer and software. And this is another example, for example, for 5-ALA evaluation. This is here the fluorescence signal with the use of an endoscope. And I'm sure because the endoscope is much closer to the target area, the endoscope, in our experience, we have done a couple of this with a prototype with a 5-ALA endoscope. The sensitivity is much higher than with a microscope because you don't lose all the light with a distance of 30, 40 centimeters from the lens to the surgical field, because here you are right to the target with 2-3 centimeters away from the tumor tissue. So I'm quite sure that endoscope or exoscope, I mean digital imaging, will play a major role in the surgery in the future. And I'm sure that in 10 years from now, maybe 20 years from now, nobody will still have a standard microscope anymore. And well, this is again for those doctoral students who helped me, and thank you. And you're invited to come to Germany when you are allowed and world is safe again. Thank you.
I think Dr. Deopujari had some problems with the internet. He's joining again. Let's see.
Okay.
So meanwhile, this 4K and 8K endoscope will be digital or?
Yeah. Well, the more magnification we have, and the more the further developed cameras we have, this will be then we will have all digital. We will have only I think in 10 years from now we don't have the camera systems anymore. We just have chips. If they're in the tip of the endoscope or exoscope or whatever, we will have small chips, and then it's like a iPhone or whatever, like a cell phone. You have
it's a digital
you will
endoscope.
have very good results, and will be all digital, I'm sure.
So it will be a digital endoscope.
Yeah, I think so.
Oh. Nilesh, are there any questions now?
No, sir.
So I'll start with my presentation. Meanwhile, we'll see whether Dr. Deopujari can join us again. Okay.
Yes, I think go ahead.
Yeah. I'll just share my presentation. Okay.
Yes.
So I'll be talking about 3D endoscope, endoscopic spine surgery. I'll just try to summarize my journey from the single chip to 3D and how I have used that to create a brand value. The practice in other countries and in India, they are completely different, and I'll be able to answer the question about why microscopic, or what is the difference between endoscopic and microscopic, and how I have used this to create my brand value. This is about the 3D technology, 1990, Baker et al. They thought that it will be better for the better recognition of the relationships of the anatomical structures. This is in 2002. I thought of learning neuroendoscopy and spinal endoscopy both in Mainz and in Bordeaux. This was the neuroendoscopy training in Mainz. And after that, I thought that spine will be better for me in my small town. So I continued with that, and that was my love. I chose the spine endoscopy and continued with the spine, and I did it persistently, focused on it. And the application of the keyhole surgery or MISS does not require the latest technology, but it requires willingness to change your mind. But the latest technology will help you in creating your brand value. This was in 2004. We did the first live demo with the single chip camera. This was the single chip camera with halogen light and everything. And at that time, we use this 14 inches Sony TV. And this is the single chip camera. It went ahead with the 3 chip and then the HD. And when I started using the endoscope with the single chip camera for the anterior cervical, it was a little bit stressful to drill the bone near the vertebral artery. So this was the vertebral artery and the disc through the unconvertible joint foraminotomy, and this was the medial border of the vertebral artery. So it was really stressful because everybody was skeptical and to use drill, and there was always a stress for these type of complications. So I thought of using something which will be helpful to remove the bone. So I discussed all these things with the Zurich people. We had these prototypes, and then we had this ultrasonic bone dissector. This was the prototype. I am medial to the vertebral artery. So this relieved my stress little bit. This was the cord diagonally going to the opposite side. And then it came the HD camera. The vision was quite good. We could appreciate the tissue planes, midline between the two side flavum attachments. And we use this HD camera in the third course. We were able to put the endoscope inside the disc space, and we had a quite good image, the high definition image. We could see inside the disc space also. But still there was this skepticism. And in each and every workshop, we used to train people how to have this 3D appreciation of the 2D HD image. And this problem was overcome by reconstruction of the anatomy in the surgeon's mind through the use of multiple landmarks, that is the suction tip, the lamina, and the instrument strip. But this requires additional effort and a steep learning curve and a sort of a telekinetic slowing of the surgeon's actions. So there was always a skepticism, and we had in mind that we should have something with endoscope with a 3D appreciation. So these are the 3D techniques which were available at that time. It's a conventional telescope type stereo endoscopy with two separate endoscopes channels, which does not allow the diameters below 8 to 10 millimeter. So initially the laparoscope was in the market, and the 4 mm 3D endoscope for the spine and neuro, it came later. And we had this 3D endoscope which were 4 mm diameter, 18 centimeter length by Vision Sense, Mashida, it's a Japanese company, and Stars. We had this 3D video converter which converts the 2D image into a 3D by distorting the image by Mashida. So this was the Vision Sense. I used it in 2016. This was the 2D video, a right eye video of the 3D. And we can appreciate the anatomy better, the depth appreciation. This was the nerve root and the disc removed from the shoulder of the nerve root. I use this for canal stenosis, bilateral decompression using unilateral approach, and the intradural tumor. I first used 3D for the intradural tumor so as to judge the depth appreciation. This was ipsilateral nerve root decompression, bilateral for the canal stenosis, and this was the endoscope by Vision Sense. This was we have to use 24 inches monitor. It had a rigid rod lens type, and they would create two images, one left eye and one right eye through these lenses. So the insect eye technology was used, and the multiple images were converted into two videos, left eye and the right eye, so as to get the 3D appreciation. This was the canal decompression, ipsilateral, contralateral. This is the ipsilateral traversing nerve root. This is the contralateral. But this endoscope head was not circular and camera has to be fixed over it. So we were not able to rotate the camera to get the correct direction of the orientation of the anatomy. So the camera, we have to fix it here. So I did some modification in the locking system so that the camera with the endoscope can rotate inside the sheath of the endospine. You can see this is not in correct direction. There is something around 25 to 30 degree parallax. It is not exactly in the same direction as the patient's anatomy. This was the first case I did with the 3D endoscope by Vision Sense. But I did something around 20 cases with Vision Sense. But there was a fear that it has some problems, and I was not able to. I was not convinced about the future because they had some technology where after 70 cases we have to change the endoscope. So then I shifted to Mashida 3D converter and I used it for 1 year from 2016 to 17. It converts, distorts the 2D image and had two images, and this is how we get the 3D appreciation. So the 2D image is put to the 3D converter and then it is shifted to the 3D monitor. So this is the 2D 3D image converter. From the 2D camera, the image goes here and it is converted into a 3D. So I used this for 1 year, about 100 cases. And these are the 2D videos of this 3D converter. You can appreciate the vessels over the nerve root here, the epidural veins. The best part was, as we are using the 2D image, we could have the advantage of the panoramic vision of the 2D endoscope. Then in 2017, I started using this 3D endoscope, TipCam 3D by Stores, which is same 4 millimeter diameter, 18 centimeter length, dual chip technology, and this is the endoscope. It is very light, autoclavable with the 36 inches monitor. So these are the two images we get. This is the disc, nerve root after decompression. These are the two videos. We have to have a 3D monitor to appreciate this 3D. But you can appreciate the crystal clear images here. This is the traversing root, shoulder, axilla. This is the 2D image of the 3D. And this is the 2D video. So with this Stores 3D, I did around 332 cases, lumbar 296, cervical anterior 15, cervical posterior 10, intradural tumor 9, and thoracic 2. I had 3 dural punctures. So even if with a great magnification, these complications like dural punctures or injury to the dura are still there, and all the cases, all the 3 cases were of canal stenosis with listhesis. But as the dural punctures were very small, there was no need for suturing, only the gel foam and a small muscle piece inside helped. So we use this 3D endoscope with distended technique successfully without any extra time or fatigue. It is easy for the beginner, as there is no need for the learn the technique to convert the 3D into 3D appreciation with the 2D image. It is suitable for complicated cases like re-surgeries where there is severe fibrosis, intradural tumors, and cervical anterior where the foramen anatomy is something around 10 millimeters only. So definitely best for canal stenosis where we have to angulate and go to the opposite side in a very narrow corridor. So this 3D appreciation will definitely decrease the steep learning curve for the young surgeons. 3D anatomy helps in explanation of this disease anatomy like compression of the nerve root to the patient's relative. I usually call the patient's relative inside the OT and explain them the disease, the nerve root, how it is compressed, how it is under tension when there is a huge disc. We put the endoscope inside the disc space and show them how the annular tear has occurred and how wide is the annular tear. And I usually explain this anatomy with the 3D video to the patient after the surgery also. So they appreciate it very well and they can understand the disease process. And that's how we can have a patient education with this. And this 3D technology I have used to change my training module. This is the first day where we go to the cadaver. And this is the intraoperative, the delegates come into the theater and they have a appreciation of the 3D anatomy during the surgery. This is inside the OT. And then we give this cadaver 3D endoscope for them after having the 2D endoscope cadaver training. They can use this 3D endoscope and appreciate the anatomy in the cadaver also. That helps them to understand the anatomy and the depth appreciation. On the third day, again they go to the cadaver. This is one of the slides when I presented this in Homburg in your spine endoscopy week. This is a portable endoscope, so you can carry wherever you want. I go with the endoscope to the another surgeon's OT and I can operate there. This is in Jabalpur. So I use this 3D technology for patient education. Patient's relative can come into the, they come into the OT and understand the anatomy and the disease process. And I put the endoscope inside the disc space and show them how the annular tear is there, how it is going to heal. And if it doesn't heal, there are chances of the recurrence in future. So they can understand the disease process and the post-operative period understanding is better when they understand the disease process well. So there are some pitfalls. We use the endoscope for the panoramic vision, but with the 3D endoscope, there is no panoramic vision. We cannot have a zoom effect. In the 2D endoscope, there is a zoom facility, but that we cannot have with the 3D endoscope. The 3D converter, we are using a 2D endoscope. That's why we can have a zoom effect. But there is no panoramic view with the 3D endoscope. But the illumination of the periphery and the razor shaft image is much better as compared to the 2D image. So this stand-use technique, there is a sliding movement between the outer tube and inner tube. I use that this thing to have the zooming effect in between the pathology and the endoscope. You can zoom inside, have a look at it, and at the same time the endospine is movable, so I move in all directions so that it can give me a panoramic view of the periphery of the operative area. So when I am finished with the use of the instrument, I slide down the inner tube down, have a look at it, what I have done with the 3D, understanding the anatomy. Then I come out little bit and operate again. So this is how I use this zooming and mobility, zooming facility and the mobility with the distant view with the 3D endoscope. So I can overcome that pitfall of a not having the panoramic view with the 3D endoscope. So what has happened is I started with the single chip, 3-chip HD image. Then I thought of using the ultrasonic bone dissectors for safety. When I started using this 3D endoscope, the image was quite clear. It was a brilliant image with the very good illumination at the periphery. So the use of the ultrasonic bone dissectors have decreased considerably when I started using the endoscope. I have tried to understand the anatomy better. The synovial cysts, which were not reported on the MRI, but I could appreciate in 5 to 7% of cases synovial cyst when I was undercutting the medial facet, which was not possible for me when I was using a 2D HD image. Now I'm using the nerve root retractor aggressively because I can judge the depth where I'm putting the nerve root retractor, whether it is touching to the annulus and then retracting the nerve root. So I have become a little bit aggressive with the use of the drill and the nerve root retractor with the use of the 3D endoscope. I'm able to appreciate vascular plexus over the axilla of the nerve root, which I was not able to appreciate with the 2D magnified image also. Now, there will be some future developments in the 3D. Autostereoscopic monitors will be available in future. So there will not be any need of using 3D specs. And the strain, visual strain, vertigo and neck pain will be quite significantly less in future. There will be 3D 4K endoscope with the wider monitor in future. And maybe 3D endoscope with navigation will come in future. This is one of the case. It's a neurofibroma at D10-11 with severe stenosis. 70+ lady, and these were the incisions. We mobilized her after 4 hours, no catheter, no drain. This is in Hanover when I met Dr. Oertel during the spine course. These are the nice memories with him, with his relative. Thank you.
Yes. Dr. Deopujari has come back.
Let's see.
I am there. Dr. Dey, please.
Yes. Yes.
I think you can summarize and maybe comment on this talk.
Yeah, I think this is a very good talk by Dr. Rohidas and Dr. Oertel also. We came to know a lot of things now, new things also, the future of the endoscope. I think there are still developing and about the 3D 4K now is coming, as they are telling that robotic also there in the experiment level. I want to ask Dr. Rohidas one thing, that he has faced about 3 cases in around 300 cases of this endoscopic 3D technique, that dural tear. That is due to the pathology, that is due to adhesion or due to your technique?
Due to the pathology, because all the cases were listhesis with severe stenosis.
So that is due to the pathology, that is due to severe stenosis.
So we have to keep in mind, in future also, we will not be able to reach 100%.
There are the three things you told, that now you have to give up that using the ultrasonic bone dissector because of your depth perception is far better than the 2D.
Yes.
And that's why you have no need to use the ultrasonic bone dissector.
It is there in the OT, but I very rarely I use it nowadays.
And one more thing, you told that you are rampantly using the Norwood retractor nowadays, which was previously used to advise the newcomers that not to use the Norwood retractor.
Yes.
Because it may injure the nerve root and the neural structures if you are using more than 20-30 seconds.
Because of the 3D anatomy and depth appreciation, I have become more aggressive.
About one thing that you told that you are more detailed picture you are getting of this epidural vessels.
Yes.
That
this is something the I am able to see synovial cysts which were not reported or not seen on the MRI. Some arterioles, each and every nerve root, there are some arterioles. I'll be able to show the pictures in future of this presentation.
Do you mark any difference between the bony sacrifice of the 3D technique? Are you using, or are you sacrificing the less bone?
Yeah, I'm trying to save as much as more bone as possible.
For the medial aspect of the sacrificing the
lamina
medial,
also, the facet also, everything.
Yes.
Because I can undercut the laminas to detach the phloem rather than totally excising the lamina.
The synovial cyst you have marked, that is usually the facet synovial cyst.
Degeneration.
So that in 3D you are diagnosing the
I'm able to see, it's a magnified anatomy with quite good illumination. I'm able to see more and more synovial cysts when I'm undercutting the facet.
And you also told that the dural tear is smaller in comparison to the 2D?
Yes, it's a smaller dural tear, but even if with the 3D, very good illumination, very good magnification, you can have these dural punctures.
Can I ask Dr. Oertel, your dural tear in comparison to the this exotic and microscope, exoscope and microscope, is there any difference of the dural tear?
Well, we haven't had the dural tear so far with the 3D. So I don't know.
Less. Yeah.
Yeah.
Okay. Nilesh, any other question?
Right now, no question, sir. Hello, can you hear me? Right now, there was no question.
Yes, we got it.
Good.
Sir, for my sake, I just want to ask something. The price of 3D endoscope as compared to 2D endoscope, what means?
It's really exuberant as compared to 2D endoscope.
3D endoscope is much costlier than 2D.
It's costlier, yes.
So, what is the difference? So, just start with 2D, then convert to 3D with case loaded.
It's always better to start with 2D. Then when you are well oriented, then you can start with the 3D.
2D,
yes, two things I came to know. Nilesh, please. Two things I came to know from the Rohidas talk, the 2D and 3D, that the difference, that the lacuna of the 3D, that the panoramic view he is not getting, and also the magnification he is not getting. So what he is doing, that he is using, that we are using the destined to technique. So in destined to technique is a mobile operating tube. And also you can go inside because there is a telescoping locking system. If you go inside, if you go deeper, the magnification will be better. So what he is doing, he is taking the advantage of the destined system, that telescoping locking system, and then the mobilizing system. So that's why that is almost like a symbiotic combination of 3D and the destined system. How it is, I think I just want to know about this Oertel 3D endoscope in your EasyGo technique.
Well, so far we have no 3D application of the endoscope EasyGo. Well, right now, I think, I personally think that the 3D endoscope is, well, at least in the way we use the endoscope, is not required. I have used the 3D endoscope in some scar-based cases, but to be honest, I think it's, if I had the choice, I would use the 2D technique. I think it's, if you're used to the technique, it does not give you an additional information. And because usually you have a suction device or whatever in the depths of the surgical field, and you just have this depth perception. I don't know what will be there in the future, but I think right now it's not ready for this small endoscope applications.
Correct. I think it is clear. Okay.
Sir, a similar kind of question came from Dr. Alok Oja from Varanasi to Dr. Rohidas sir. Do you advise youngster to use 3D if they can buy it?
No, no, they have to follow these things. They have to try with the 2D at their own place at the hospital, get oriented to the system which they are using, and once they are very well versed, then if they have money, they can shift to the 3D.
Sir, how many cases
Don't
you
go
would
for
advise?
3D directly. This is like, for an endoscopic spine surgeon, they should know the open anatomy first, and then they should change to the endoscopic system. Don't go for the endoscopic technique directly before
Sir,
understanding the technology.
Sir, how many cases you are advised to do under 2D, then you can convert to 3D?
No, that also depends. Initially, you have to start with the simple disc. Then we have to start with the canal stenosis. And when you are very well versed with the system, then you can change to the from 2D to 3D.
All is a learning curve. That depends on the person to person how he is well versed with the system. Because
Yeah, also talent is different. You know, for one it's very easy, and for the other it's very difficult. So you
and that
have to have
depends
an
upon
individual plan.
Cases which are available. The cases in Germany, cases in Korea, and cases in India are completely different. So you have to think about your own setup, whether you are in an institutional practice, whether you are in a private practice, whether you have a very small setup or a big setup where all the things are available. You have to think so many things. You have to think of so many parameters. I have my own setup, so I have tried to use this technology to create a brand value out of that, so that the patient education is quite good, and each of my patient is my business card. So I don't have to use another technique for another thing for the marketing of my technique.
Yes, Nilesh, I can tell one thing to
Deopujari sir, any comment?
No, I think as Dr. Oertel was saying, I mean, I have tried to use 3D endoscope for skull base and for were very, very impressed. Somehow the headaches and the other factors associated with it, we did not go for it. And we are still very comfortable using the, if you have a good HD screen, I think since the days I have started doing endoscopy, I think one of the biggest changes I find that our technique has improved or our patient outcomes have improved is with the introduction of HD technology. I think that has made a huge difference. After that, I think it is a question of individual preference. But I think there is no substitute unless you have a good HD and maybe 4K. I think you are handicapped. So I would not compromise with at least having a HD system as the basic requirement.
I think particularly if you don't have a big contrast between tissues, so in like endonasal or in spine, I think there HD makes a tremendous difference. Yeah, interventricular, it's not really a difference. You don't need HD. If you use endoscopic assisted just for inspection, you don't need HD. But if you, for example, have the endonasal mucosa, if you have the muscle tissue in the spine, I think HD, it really makes the procedure doable. You know, without HD, don't try.
What about 4K in future and then 8K?
Well, I have used 4K in spine. It's nice, but it's not such a significant difference than standard to HD. Standard to HD is a completely different world. HD to 4K is still similar. It's like iPhone 10 to 11.
Okay.
Because they will be coming with 4K 3D in future.
That is maybe
Because
different.
they have 4K 3D in laparoscope now.
Well, I think the biggest, the most urgent developments in the exoscope are integration of the molecular imaging. You have to have ICG, 5-ANA, you have to have, you know, all this analysis options. We use like confocal, like contact. Why don't we use this? We have a digital image, so we have to use all the different options and improve the software that we have additional information. This will not change the responsibility of the surgeon. The surgeon is still responsible for performing a successful procedure. You know, but I don't think that it makes a big difference. 3D, 4K, 8K, you know, HD. It's not we need integration of the molecular imaging in the surgical armamentarium. And this will change the results in a lot of indications in the future.
The same thing, the muscle trauma, because of putting the endoscopic instrument inside, it will be same with the single chip, it will be same with the HD, and it will be same with the 3D. That is not going to change.
Yeah.
The approach related trauma. Only it is the surgeon's this thing that he will be able to
The tissue differentiation
understand the
and
anatomy better.
detecting ability certainly gets affected. So,
well, I think, for example, just pretend you perform aneurysm surgery, and you know the system itself analyzes the perfusion of the branching vessels, and it tells you all branching vessels have a nice perfusion. I'm sure that a huge number of cases, you know, would benefit from this.
absolutely.
Absolutely sure.
Yes.
And this is what we need, next step. It's not that we need a better resolution. No, we need integration of all the molecular imaging options we have now on the market or under investigation, under development.
Can I ask one question?
Yes, Nilesh.
There are a few questions coming right now. This question from Dr. Anil Kulkarni from Bangalore. Here he's asking, is it advisable to start with preliminary training with the angled endoscope itself?
So that depends upon the technique which we are using. Whether a particular system is using the angled endoscope, you have to start with the angled endoscope. Dr. Oertel?
Well, as I said, for example, it depends highly on yourself, on your cases, on your situation. For example, we in our department, we have a huge range of different indications. So it's completely different, the requirements of the systems you use, for the systems you use. Then you are in a private practice and you have only disc plots L4-5 right side, for example. You know, then you just need one system which which are able to treat a 4-5 soft disc prolapse with. So this, you cannot make a final judgment on this. It depends on your personal individual situation.
Correct. Absolutely.
This question from Dr. Ram Prasad, who is from Bangalore, is asking for a Deopujari sir. To Deopujari sir, tips of endoscopic skull-based surgery. Dr. Ram Prasad asking some tips on endoscopic skull-based surgery. This is very wild.
Well, I think as I just said, in terms of instrumentation, you should have a HD system. I think that is very, very important. And I'm not convinced with the fact that you're doing a dynamic kind of a endoscopy at the skull base. 3D may not add too much to that. What is important is if you are going to use a mononostril approach, you have to learn how you are going to maneuver your instruments properly. If you are going to use a binostril approach, then you need to make sure that you don't destroy too much mucosa, and you should reconstruct properly. I think these are the very basics, and then depending on what pathologies you decide to treat. But I have no hesitation in saying that unless you do at least 50 good pituitaries, you should not try to do any extended procedures.
Can we go to next question?
Yeah.
Yes, go ahead.
So this question from Dr. M.H. Dey from Dhaka, and he is asking that review on endoscopic posterior fossa, cervical spine and colloid cyst surgery.
Posterior fossa, what? What was the question? I didn't get it right.
Yeah, repeat the question, Nilesh.
He is asking reviews of endoscopic surgeries on posterior fossa, cervical spine and colloid surgeries.
Revenge. What is that?
In our case series, posterior fossa endoscopic.
No, what do you want to know about colloid cyst?
Any review? He was asking reviews of colloid cyst surgeries on endoscopic posterior fossa surgeries and cervical spine. So a very wide range of question. This is he wants our reviews from three kind of surgeries.
We'll go to the next question now, because this is very vague question.
Apart from the indications which you showed, Dr. Oertel, I saw one group. I think the Tübingen group. They are doing posterior fossa tumors with exoscope quite regularly. I think.
Okay.
Schumann was showing some cases with pediatric tumors. So I think they probably haven't come out with any publication yet, but that may be another indication where you can use it. Have you used it in the posterior fossa cases for microvascular decompression or for tumors?
We have used it. It's if you have like an epipneumoma or something, tumor in the fourth ventricle is fine. For a supracerebellar infantile approach, like a pineal region, I don't think it's too dark. I don't like it.
Right.
So more or less the standard, I mean, rather the wide approach is that it's good.
So basically what you're saying is for superficial lesions, it works well.
Yeah, yeah.
Nilesh, are we done for the day?
Question finished, sir.
Perfect.
Great.
Perfect timing also.
So we will stop recording. We'll have some discussion and then we'll leave the meeting. Nilesh, can we stop the recording now?
Yes, sir.
Yeah.
Sir, one more question from South Korea just came in.
Oh.
Yes, go ahead.
This question from Dr. J in South Korea. Can prevent brain infarct and old infarct by endoscopic surgery?
Difficult question to understand.
So it's a very difficult
what
question.
surgery are we talking about?
So he just want endoscopic surgery for a prevention of brain infarct or old infarct. So I'm not able to understand this is also.
No, I
Is
don't.
there any advantage of the endoscope to
We'll
reduce the brain infarct?
then we'll skip the question then. It's
Yeah,
not
sir.
directly related.
Sir, before we stop recording, I would like to just officially thank our international speaker, Dr. Oertel, on behalf of Health and You and on behalf of all the Indian doctors for giving us a brief of history, exoscopy technique, and the future, the peek into the future of exoscopy and endoscopy techniques and the things to come. So thank you really for your excellent, wonderful presentation, Dr. Oertel. We are very, very thankful to you. Dr. Deopujari sir, thank you very much for your coordination, expert guidance and advice. Dr. Rohidas sir, for once again showing your technique and also the 3D technique that you use and how useful it is. Dr. C Dey sir, for asking relevant questions and making the discussion very, very interesting and enlightening. And Dr. Nilesh, for helping us to coordinate the questions so that the faculty can give answers. So thank you audience for joining us today, taking out your valuable time. I'm sure you must have found the discussion, the technique, the presentation and the future discussion about the future very interesting and enlightening. Thank you very much for taking care of COVID-19 patients during this crisis. We request you to support Health and You and Health and You products. And on behalf of Health and You, this is Deepak Naik signing off from here. Thank you so much. We had a record logins. We had 735 doctors logging in from different countries and from India. So thank you very much once again for all the faculties for your power of pulling in audience for a lively, meaningful, enlightening discussion. Thank you so much. Now you can close the recording and then can discuss. Yeah, thanks a lot. Thank you very much, sir. Thank you.
Thank you.
Thank you. Thank you.